To summarize kind of where we're at through with the change in our program, we mentioned we have the hotlines, and these have been fully active and tested. Our no divert policy been in place for over 2 years now. Our hotline has replaced the transfer line. Some people still get hung up on this, and they call transfer line to get a heart attack, and then that slows the process down. Even though the transfer people are very nice people, and they really are working hard to improve their system, for STEMIs, every minute counting is just too cumbersome of a process to use that line. You all treat STEMIs more like trauma, so that's changed the way we handle these. I mentioned the field EKG, and we can expect a false positive rate to 10 to 20%. This is pretty clear nationally, and nobody should feel bad if they find out that what they thought was a STEMI was not a STEMI. We see this quite often, and we don't want to punish anybody for running into one of those. We have had a number of ECG training sessions, and we do share data. Our EMS people come. We have a regular monthly meeting. It's in a pretty big room with all the key people, ER people, doctors, nurses, CCU nurses, EMS, Lifeline, and we review every single case that comes in, and we look at the times. We look not only our local in-house patients, but we look at our what we call transfer STEMIs, the people coming from areas like this. We have also developed more refined a new version of our order sets, which we make available to anybody who wants to have them. And they really are state-of-the-art. Dr. Ty Gluckman, who works with me, is on boards for national organizations with the American College of Cardiology and is in charge of functions related to guidelines. And so he's spent an exhaustive amount of time to get these order sets kind of perfected.
And Ocean Beach uses those order sets essentially.
Great.
They've incorporated those into their standard care, which is great.
One of the goals of our order sets is to avoid trips, because we know that adding trips increases delay. So you all experience that. If you have to change over pumps, you can easily add 20 minutes or a half hour total time in messing around with these strips and tubing. Our ED is kind of fully plugged into the rapid activation protocols. There have been some changes recently. What was door to balloon is now changed to first medical contact balloon. So this puts a lot of heat on us now. So from the time you all pick up a patient, where the clock is running. Now, we understand that people out here aren't going to be treated first medical contact balloon in 90 minutes, but I just want to give you a sense of the kind of pressures we're under to make this happen. Wow, we're doing really well with that. What's more applicable out here at the coastal centers is this door in, door out concept. And I'll talk about one of the recent articles just published in JAMA that proves this. But our target is that a patient, if at all possible, should stay in the emergency room only for 30 minutes before they get moved. And we realize there are weather barriers, there are transportation barriers of all kinds. But it's an extraordinary challenge for the local hospitals here to meet this target, but it is a target, and we'll talk about how successful they can be with that. We have reduced our use of beta blockers. We no longer routinely give intravenous beta blockers, and even less oral blockers, as the data is really not supported. Benefit, it may be harmful in people who are in difficult hemodynamic conditions or heart failure, so it may make things worse. We also have gotten away from what we call 2B, 3A glycoprotein receptor blockers, Integralin being one, Riopril being another. These drugs were commonly used in the last decade, and started often in the coastal hospitals while patients being shipped. And we were able to get away from this by using oral Plavix, 600 milligrams oral Plavix, aspirin, shot of heparin, back in the truck, in the Lifeline, whatever can get the patient moving. We've also, Marla and I, we've also developed programs for in-house, what we call in-house and clinic STEMIs. We found that we have these amazing door-to-balloon times from our ER, but if someone on the 6th floor of our hospital had a heart attack, a STEMI, it may take 3 hours to get that patient taken care of. It's amazing, but there was really no protocol for handling those. We have people to review the EKGs, people have to respond in a certain way, And the same applies to the PMG clinics, the Providence Medical Group clinics, for example, and other clinics nearby. If they have someone walk in their door with chest pain, they get an EKG and it shows a STEMI, there's great variability in how those patients were handled. And by setting up a process to simplify it, to make it an emergency code situation where they just get packaged quickly and off they go to the emergency room, and the emergency room's contacted. All those things were really remarkable in helping them. I think after we set up this program, we had like 8 STEMIs in the PMG clinics in the following several months. So it was pretty dramatic.
And they all did an amazing job just following the protocol. All they needed to know was how to access the system. And once they knew, it's like, whoosh, we got it. That was great.
This door in, door out concept, so this Dr. Wang's publication in June's JAMA, this is a retrospective analysis of over 14,000 patients between 2007 and 2010 at a whole bunch of different STEMI centers. And we found that the mean door in, door out time was 68 minutes, pretty long, so pretty far away from the 30-minute target. Only 11% made it under 30 minutes. I would say in our system, probably Newburgh Hospital is currently the best at this, although Ocean Beach Hospital had a remarkable case recently we'll talk about, because we have to have life flight there at the door. But the mortality, there is mortality difference between these times. So if you're under 30 minutes door in, door out, you have a mortality of 2.7% compared to 5.9% if it's longer. So it really does translate into the whole concept of get them earlier, they're going to do better. If we look at door to balloon time under 90 minutes, we had 60% versus 13% when the door in, door out time was under 30 minutes. Again, all these different centers have different specific characteristics and distances from PCI centers. If we look at this just simple cartoon here, this time cartoon here that talks about the pre-hospital situation, you're tied in the emergency room, and I can put this block in here for a waiting time where you're waiting for life flight to get there, you're waiting for an ambulance to become available, and you have transfer time. Even if we made this happen, it's very possible at many centers that we can get our hand on the patient at about 90 minutes and then give us a half hour if we need to fix things up. And this 2-hour window may not fit the ACC's ideal optimum of 90 minutes, but when you look at the survival data and morbidity mortality data, it really extends out beyond 2 hours benefit for primary angioplasty compared to lytic therapy in many patient subsets, in fact most patient subsets. It's a whole different topic to just talk about angioplasty versus lytic therapy. I could go on and on about it. Even when ambulance crews in Europe were giving lytic therapy en route, there's still only a small subset of patients that beat angioplasty. And it has a lot to do with the time of symptom onset to presentation. So you know that for a long time it was 2 hours before anybody really got help from their chest pain. We still see this all the time. I'm sure you see it all the time when people wait and wait and wait. And it's hard to get rid of that piece. This is 2010 for Columbia Memorial. I'm going to throw their data up to illustrate a few points. So these are kind of slides that Marla has put together, and I didn't include the legend here. Of course, the red ball is the balloon time. The zero time is here when the patient gets to us. The whole idea is if you have a positive EKG, this is a field ECG positive STEMI, the yellow diamond. This would be a positive ECG STEMI in the emergency room. The little slash here is when the patient got to the hospital. So we might see patients who have a positive EKG, and then there's this little gap of time when they get to the emergency room. The red box here is when the STEMI call was activated, hotline was activated. The green box here is when the patient left the emergency room. So This little bracket I put in here just to remind you what the 30-minute gap is, and you can kind of visually run this over, but you can see that in 2010, even with our program pretty well in place, the door in, door out time is really higher than ideal in these patients. So there's a lot of potential savings in this area. We know that we can't do much about this time, which is the time it leaves the emergency room to the time it gets to our hospital. We can control this piece up here. This is the gap we don't have much control over, but we do have some say-so here. One of the ways to help that along is when you contact the ER, for example, Ocean Beach Hospital, if they fire up the STEMI program or the STEMI activation right from your phone call based on your reading of the EKG, we can have things in place and moving and save a chunk of time. I'm going to go through this briefly just to give you a concept. Don't get too hung up on this, but I want you to understand a little bit about these box plots. So in this particular graph, we're looking at STEMI times origin to departure. And the way this works is like this. So if we have this group of patients demonstrated by this bell-shaped curve, and the median follows it right there in terms of times. We have the 20, if we cut out the lower 25 percentile, the upper at the other 75 percentile range, we get this kind of 50% of cases in the middle. So it helps you understand a little bit when you look at this, these boxes. So here's the 50% of patients. Here's the range. These are outliers. They skewed the data and they didn't really help us through this, so we just labeled any outliers up here. But this little black bar across is actually the median. And when we look at the target of 30 minutes door in, door out, we can see that almost everybody falls above. I believe these are hospital centers here by letter, and I think Newburgh was the closest at the time we put this first set of box plots together. And but you see there's quite a range. We kind of asked the question, if 25% of the patients can leave in this time, why then do the rest of them have to leave at this time? You know, if you can do it for some, why can't you do it for others? And there may be reasons, but and we also have transfer times. We realize that the centers farther away take longer time to get there, and that's going to be harder to control. But there is even variability. Some of this may be weather. Some of it may be, you know, helicopter versus ground transport. So summary of here are the things that help reduce STEMI times: life flight activation before the emergency room arrives.